Tēnā koutou katoa, no mai haere mai. Welcome to our third webinar, brought to you by the University of Otago postgraduate program and the Division of Rural Hospital Medicine. We are all living through very strange times, and while COVID dominates our lives and our minds, we must continue to think and learn like the broad-minded doctors that we are. So tonight, we have a shift away from COVID and bring you an update on stroke and its management. Now, before I introduce our guest tonight, there are a few housekeeping matters. I feel like I need to give little instruction on how to use Zoom, as I'm sure you've become much more familiar with it in recent weeks. But I will just remind if you can leave your microphones off, because that just improves the sound quality, and likewise with your cameras. If you have any questions during the evening, if you could enter them into the chat box, and Gary Nixon in Dunstan will be keeping an eye on those and collate them, and I'll go to him several times during the evening to address those questions. I would ask that at the end, if you wouldn't mind taking a moment to complete the survey, that the link for this will also be in the chat box. Rory will be putting that up several times during the evening. This link and the survey provide an opportunity for you to give us feedback, which is really useful for our future planning. But it also allows us to access your medical council numbers so that we can enter your details to the college, so your CMA points can be lodged without you needing to do anything. So moving on, I would now like to welcome our two expert guests tonight. So firstly, Dr. Steve Withington. Stephen is an internal medicine physician and rural hospital specialist who works at Ashburton Hospital. Steve is also part of our University of Otago Rural Postgraduate Program. And with us from Christchurch is Dr. Teddy Wu. Teddy is a stroke physician who specialises in the acute management of stroke and has been a leading figure in setting up acute stroke treatment pathways and telehealth across the South Island. So I'd just like to say thank you so much to Steve and Teddy for generously sharing their time and expertise with us this evening. So Teddy, if we start with you, I just wondered if we could touch on some of the pathophysiology of stroke, just to remind us about a little bit about that, in particular reference to the penumbra.
Thank you, Matilda, and thank you, everyone. I'll just share my screen because I prepared a few slides to home in that concept. If I can find the right buttons. Sorry, try again. Oh, for some reason the slides isn't showing up. Can everyone see the slides at the moment, Matilda?
I can see your desktop, and I can see a single slide there, acute ischaemic stroke.
Okay. Yep. So it's playing. Sorry about that. So the concept of ischemic stroke is actually quite simple, as represented in the diagram here, and I'm sure most of us will be familiar with this. So when you have a stroke, most of the time it's caused by a blockage or clot in a artery in the brain. As represented here, it's in this case it's a big artery, the middle cerebral artery. The black bit in the vessel is the blockage, and because of that there's reduced blood flow beyond that area, that region, and because of that you have an area of the brain that's ischemic, which is represented by both the round grey circle and the wider region oval purple area. Within this region, then you there's two separate subclassifications. So you have what we call the core. So the core is the area of the brain that's already dead at the time of scanning, and doesn't really matter what you do or how quickly you restore blood flow. That brain is already infarcted and will not come back despite treatment. While there's a larger area, the penumbra, which Matilda referred to in the shaded purple area. So that's the important target for stroke, because that's the area of the brain that's under oxygen deprivation and has ischemia, and that's causing the stroke symptoms. But it's potentially reversible if you can restore blood flow in time to prevent it from becoming dead brain tissue. Just to reinforce this concept, this is actually a scan. These are the scans of a real patient who had a clot, as you can see in the middle cerebral artery, the white bit there, pointed by the arrow on the right. And now we bring you to this video, which is a perfusion scan that's mimicking the blood flow in the brain at the time of the stroke. So as you can see there, the right side, which is the left side of your screen, because it's opposite when you look at CTs, there's the contrast, which is the blood, has a delayed uptake to the right-hand side compared to the left, but it's not completely absent. And because there's still blood flow, it maintains the survival of the ischemic tissue, or what we call the penumbra. And then we can do fancy processing to come up with a map like this in the middle, where the green is the penumbra. You can see a large area of the right hemisphere is a risk of progressing to dead tissue, and you have a small amount of core, the red bit in the middle. So what happens is this mechanism will then progressively fail if you don't restore blood flow in time. So this is the same patient, when he first presented. Unfortunately, therapy wasn't successful, and 10 hours later, we repeated the scan, thought we might be able to retry treatment again. But you can see in a space of 10 hours, the mechanism to support the blood flow in the brain has already died. And you can see the difference between the two videos. There's minimal blood flow now to the region beyond the blockage. And now all the penumbra, essentially all the green areas have progressed to infarction. And this is what happens in real life and schematically as well. Although we'll talk about it later on towards the end of the session, that the speed at which the brain dies, or the mechanism supporting the penumbra fails, varies widely between individuals. But because in this patient, the mechanism failed relatively quickly in a space of a few hours, you can see that there's now established stroke. The dark area on the right side of the brain pointed to by the arrows, that's already that's dead brain compared to when he first came in. Initially, you can't really see any acute changes there. There's a couple of slides left on this first part. So if you are able to get rid of the clot through treatment, which we'll touch upon later on, you can limit the ischemic core, or the tissue that's already dead, to that small area, while the rest of the brain is salvaged, and you get recovery of neurological function. And just a peek about what we're going to talk about later. This patient, another patient who had a clot, a similar sort of penumbral maps, so large area of tissue at risk, but small area of dead brain. Just have to say that all these is predictive only. It's not, it's accurate most of the time, but not all accurate. Sometimes there's artifacts, so these widespread red dots are not really the core. And the clot got removed really quickly, and then this is the MRI showing a small area of the stroke, so demonstrating that most of the penumbral tissue is salvaged. Okay, that's where I will stop for the segment of the talk, Matilda, and I'll hand it back to you.
Thanks, Jenny. If you just press stop your screen share.
Stop share, yep.
Perfect. Thanks, Didi. I mean, although we definitely can't do those kind of elaborate scans and things, I think are really illustrative, and particularly when we move through the talk and touch on clot retrieval and things later on, I think it's important to hold those ideas and that idea of that retrievable tissue in our minds. Steve, if we move on to you, I think that we all are aware of the risk factors of stroke, and I think probably something I felt like I was a bit removed from is what's the current evidence around the sort of hierarchy of those risk factors? Like what matters most when we're faced with these people before they have these events?
Thanks, Matilda, and thanks for the chance to be here tonight to you all. The underlying mechanism behind most of ischemic stroke, at least, is atherosclerosis, isn't it? So the risk factors are familiar to us all: hypertension, smoking, diabetes, increased cholesterol, obesity, poor exercise, and all of those things are going to come into play, and we'll talk about them a bit more later, I think, in terms of primary prevention. But then you've got other issues like atrial fibrillation, which is an incredibly important risk factor. Maybe not as common as hypertension, which probably bubbles up to the top if you're looking at those all those risk factors just in terms of its sheer prevalence in the population. But as a risk factor on its own, the relative risk of having a stroke would be higher with atrial fibrillation. But the one that I guess we should really pay most attention to in terms of our practice, whether it's in a rural hospital or general practice, is TIA, which is often a combination, a bunch of those risk factors which can be addressed. But it's particularly important because of the major risk and the early risk of having a stroke as a result of that. And perhaps I can share one or two slides just to underlie that. I'm old enough to know when I was in med school, when I was a medical registrar, we would tend to sit on our hands around stroke and just kind of hope that it'll get better. And if there's TIA, we just sort of breathe a deep sigh of relief. Phew, that could be worse. And now we just can't sit on our hands. We've got to go for it. Stroke, it's all systems go, as Teddy will allude to, and TIA too is very much a medical emergency, is the way we frame it. So here, hopefully you can see that. I'll just enlarge that one there. TIA is a medical emergency. So I'll just go back. Because for the highest risk group, at 90 days, you've got a 1 in 5 risk of stroke. And within the next 7 days, it's over 10% in those high risk TIAs. What's a high risk TIA? Well, the ABCD2 score defines some of them, and that's where these numbers come from. And if you've got a score of 4 or more, you're in the high risk group. If you've got a score of 6 or 7, then you score these numbers, which obviously are a major concern. And half of these strokes are going to occur in the first 48 hours, and strokes after TIA are severe. Around 20% of them are fatal, 64% disabling. So TIA is a medical emergency, and we've that in the way that we organise our stroke and similar services in our rural areas, we've got to think how we can investigate these people, how we can manage these people, how we can do the best we can in a short period of time. And this is just a reminder, the ABCD2 score that we're all familiar with, and how we put it together. And then these risks, basically 90 days, as you see on the right hand side there, the low risk group, and then the high risk group, who are 4 and above. Your other high risk people are your crescendo TIAs, which are really important. Your people who've got known current or recurrent paroxysmal atrial fibrillation. People who are currently on anticoagulants. That, I guess you're more thinking about a hemorrhagic stroke in that case, but obviously they're a high risk situation. Carotid stenosis, oftentimes you don't know that, do you, when the patient presents, but they're going to be a high risk. And then of course the ABCD2 score, as we can see here. I guess the other thing I'd say about TIA and why it's so important is because it makes a difference. If you intervene, and we'll talk a bit more about secondary prevention, what can be done later. But if you intervene, and here's a study from Oxford back in 2007, the Express study, and it showed an 80% reduction in recurrent stroke at 90 days where you've got urgent comprehensive acute TIA services, compared with normal TIA services. Well, not quite my old normal of sitting on your hands, but just taking your time to work things through, if you can work things through as fast as possible. And obviously that means in a rural setting, how do we get our ducks in a row? How do we get that early scan? How are we going to search for atrial fibrillation if it might be there? how are we going to get that imaging of the carotid arteries and ultrasound? And for many of us, that's more complex. Well, for all of us, that's more complex than in an urban centre, but really important to try and, to do the best we can and to advocate for our rural areas as best we can, because these numbers are impressive. Stroke's important. They estimate that 2,500 people in New Zealand will die of a stroke every year. That sort of order. Ashburton will get about 75 strokes in a year. In your places, wherever you are, it's one of those big issues, and it's not going away. It's likely to get more with an aging population.
Steve, I was just wondering if you could comment, and perhaps Teddy as well, you mentioned some of those important investigations. I'll ask one question first with regarding to CT. Should all patients, and I'll say all patients who are not completely crumbly and frail in hospital level care, should they all be having a CT scan in the setting of a TIA?
I'll put up my hand and say yes. Yeah, but obviously that first group that you've mentioned are important. We need to think about what people's goals are, what their self-defined, family-defined, prior function-defined setting of care might be, and it's important. But otherwise, yes, CT should be done. And if they're in that high-risk group, well, it should be done within 24 hours, if at all possible, as soon as possible.
Yeah.
And
I was wondering if you...
sorry, Matilda. I agree. Yeah, I agree with Steve there. And I think one of the diagnostic values of a CT is to look for potential stroke mimics. You do sometimes, not common, but occasionally you will find a brain tumor that's masquerading as a stroke mimic or TIA. That have transient symptoms that could well be small seizures rather than true ischemic events, and that I think emphasises that I think all patients, unless they've had multiple and had to be investigated before, they should have a set of scans to just make sure there's nothing else going on.
And I guess the reason I ask is that to give us confidence so that we can advocate for our patients and push for that in a timely manner, knowing that we're doing the right thing and best practice. With regard to timing, what would you say about getting the carotid scanned?
Again, if they are in that high risk group 4 or above, there's a target to try and get it done within 48 hours. Now, if that person came to us in Ashburton on a Friday night, it's very difficult to imagine getting that done in 48 hours. We only have ultrasound once a week, but we can send people to Christchurch, and that's what we would do, and they might wait until Monday. But if they do have an ipsilateral carotid stenosis, then time is of the essence, in part because of the risks that we've talked about, the high risks of them having a stroke to follow that TIA and what that could mean, but also because the intervention of a carotid endarterectomy ideally ought to be done within a couple of weeks. So time is ticking to try and get started on that.
And what would your comments be around the optimal way to investigate for atrial fibrillation? Obviously, we have a few more options these days, and it depends on your degree of suspicion. But given what we've got in front of us, what would you suggest?
Do you want me to answer that? Maybe I'll give my 2 cents worth. You take a bit of load from you. It's a good question. Traditionally we've been requesting Holter monitors, between 24 and 48 hours on an ad hoc basis, meaning we don't risk stratify them. But unfortunately, even in patients with confirmed strokes, the pickup rate is relatively low. It has been shown that if you have prolonged monitoring, whether you have a 30-day monitor or a permanent, semi-permanent implantable device, your pickup rate increases significantly. But unfortunately, within the New Zealand public system, even in urban centres, that's just not feasible. But if someone has had a stroke or a TIA, then I would recommend consideration be given for at least a 24, if not 48-hour Holter monitor, at least a baseline ECG, or just taking a pulse before you do anything.
So we have to accept that we probably are missing a proportion who do have underlying paroxysmal atrial fibrillation, and it may be that as devices become more sophisticated, what people have on their wrist may be able to be more assistance.
Yes, I think there's some news coming through about Apple being able to incorporate a rhythm monitoring to Apple Watch, but it's whether that's economical for the hospital to fund each patient Apple Watch. You wouldn't want to have a stroke or TIA just to get that free Apple Watch, so you can get monitored. Certainly, that's a viable idea going forward.
Steve, if we first of all go back to you, I guess that leads us into the area of primary prevention for those patients who perhaps haven't had a TIA, but we deem them to be at risk of TIA and stroke. I think we'll just first of all just address sort of it from a pharmaceutical point of view, and then we'll come to Teddy if you want to comment on that, Steve.
So in terms of pharmaceuticals and which of those risk factors are modifiable, I think I mentioned before that hypertension is sort of a standout in stroke, and obviously it's relevant for hemorrhagic strokes as well as for ischemic strokes. There's quite a body of evidence now that significant modification of hypertension, particularly in the secondary prevention phase, but also in primary prevention, 25 to 35% reduction of stroke. So that's really important. And in the primary prevention side, what drugs work well. They probably all work. Although, as you're aware, beta blockers have they're not really in the front line in the same way as perhaps they used to be, unless someone's got a cardiac cause to be on them. So thiazides generally still regarded as start there. Calcium channel blockers good. ACE inhibitors are good. In a secondary prevention, Teddy would have comment on this. I mean, I tend to go straight for an ACE inhibitor, and then would consider a next addition a thiazide, and we want to get that blood pressure down significantly down. And there's basically the data would suggest that the lower you get it down, the better you reduce their stroke risk. So yeah, I think blood pressure's out there, number one. And those other things that we talked about are important too. Obviously, smoking cessation, that people drink excess alcohol, that's going to be relevant. Diabetes improvement, it makes sense, doesn't it? We're going to do that. In terms of macrovascular improvements, the data isn't as good as we'd like. And cholesterol, there's good data out there about potent lipid lowering agents.
Yep, I agree with all that Steve had mentioned there. I think there's also tools from the Ministry of Health that you can use to stratify the cardiovascular risk for individual patients. It may well be how aggressive for primary prevention you would target those people at higher risk and people with high risk lipid profiles. And smoking, I think, is probably one that it can definitely target, although the reality is that trying to stop smoking is difficult for most patients who's been on it for years, and the ones who are successful may relapse with time as well, depending on the personal circumstances. So there's definitely a multifaceted approach, not just one thing. But in pharmaceutical wise, my preference is similar to Steve's. If you have this as being a stroke or not, I personally would consider ACE inhibitor as probably one of the first choice drugs, given its other potential predictive effects and other vascular conditions as well. I think the controversial one, which you haven't touched upon, that keeps changing, is aspirin.
Yeah, that's what I was about to.
Yeah. I mean, I think there's now good evidence to say if you don't need it, don't take it. But who knows? The pendulum keeps swinging, from decade to decade. I don't know if you have any thoughts on that, Steve.
I think the latest evidence is that its primary prevention is not helpful in terms of stroke prevention, or it's outweighed by other bleeding risks. I'm not sure it's got a place in primary prevention of stroke.
Yep.
And if there's any people who are practicing a general practice out there tonight, perhaps they might want to enter into the chat box what the current practice is out there and what people are actually doing. Would be interesting to know. I guess that takes us on to then the group of patients who we're dealing with who've had TIA or had, well, we'll say stroke, and I guess it's quite obvious that we're going to carry on with statins or start statins and make sure we're on aggressive doses, that we're going to deal with their blood pressure. But I guess what's been a little confusing and changed over the years is the use of antiplatelets, which to use, when to use dual antiplatelet therapy, and for how long. And I'll leave it to who would like to comment on that first? Whoever gets in first.
I'm happy to start first, Steve. That's okay. It's controversial. I still think it is. It's it confuses myself sometimes and the colleagues. So over the years, you would all have remembered transitioning from aspirin to aspirin and dipyridamole combination, and then subsequently clopidogrel came to the scene, and for secondary prevention. And then recently, in recent years, there have been a couple of major trials looking at short-term, if you like, dual antiplatelet treatment, short-term as in up to 3 months, in high-risk TIAs or minor strokes. And I think combined, because the first study was mainly in the Chinese population, but the second study actually was a European one. But if you look at the data, there is good evidence to suggest that your risk of early recurrent event, whether TI or stroke, in the first 3 months is reduced significantly if you have dual antiplatelet treatment for 3 weeks. But this is targeting quite specific population in that the trial criteria is high risk TI using the ABCD2 score that Steve showed, of 4, up to 4 or more, or a minor stroke, using the stroke scale. These days the results seem to have been extrapolated to people with an embolic stroke, moderate stroke who actually doesn't fulfill the criteria and has been used rightly or wrongly by the colleagues. But I think the current sort of recommendation is for aspirin and clopidogrel in these patients that fit the trial criteria. So high risk TIAs, minor strokes, for 3 weeks of dual antiplatelet treatment. And then subsequent to that, most people would recommend the patient to stay on clopidogrel. Clopidogrel has a slight edge over aspirin on a large population basis. It's probably better by a few percentage points in terms of reducing recurrent strokes. But for the individual, it may not confer that much of a benefit. But if you do it widely, you're going to see some stroke reductions. In terms of long-term treatment, there's really no evidence of benefit. If anything, previous studies have shown that if you take it for a long time, as in 6 months or more, for stroke prevention, you will end up with more hemorrhagic complications and that outweighs any sort of stroke prevention reduction that you may have gained from treatment. And the other thing is, some of you, I'm sure, would have been in touch with ticagrelor, which is a cardiology antiplatelet treatment agent that I think that's being often used now after myocardial infarction. There's a head-to-head study between aspirin and ticagrelor, basically showing there's no difference for early 3-month recurrent stroke and outcome, and probably slightly increased risk of bleeding. But that's still an evolving area. But at the current point in time, most people would be recommending sticking to aspirin or clopidogrel in combination as required.
So just make sure I understand, Teddy. So the data kind of came from TIAs and minor strokes, and it was dual antiplatelet for 3 weeks, followed by aspirin or clopidogrel. Has one been shown to be better than the other as far as the long-term therapy?
Long-term, from other earlier studies, clopidogrel was slightly superior to aspirin.
Okay, and then that's been sort of further extrapolated to use in more significant strokes, that therapy. Do you have anything to add to that, Steve?
No, I don't think I've got anything to add to that in terms of the antiplatelet therapy. But I think it's probably worthwhile thinking again about blood pressure in terms of the acute stroke, if that's all right, if we can move to that one. Because it's interesting, and there's also, as I've said, whatever level it is you want to bring it down, And what is the target? Was probably about 130 systolic, something like that, to bring it down to. But then there's a lot of qualifications in the acute stroke situation, and Teddy may want to comment. If we want to give thrombolysis, well, you want it down below 185 over 110, don't you? In general, do we touch it if we can't give thrombolysis, if they're outside a window? And there's been a lot of studies around that, and in general we kind of touch it when it gets really high, up 210 systolic or something like that. Otherwise, you don't want to bring it down too low, certainly not below 140. You may not do too much harm, according to some studies, if you bring it down only a little within that range, and certainly bring it down below 185 to allow thrombolysis is a good thing to do. But there's this, how quickly do you lower the blood pressure has always been an issue, and the long term it's really important, and we probably need to work harder at it for long-term prevention of further stroke.
But there's not real clarity around the targets that you should have in that acute phase.
No, it's controversial, as Steve says. A lot of the times I think we do it to stop the nurses from paging our juniors. But the 200 systolic target in acute stroke in patients without thrombolysis is very ad hoc, and we I don't know if anybody can definitely say staying at that level in the acute phase is going to be harmful, or likewise lowering down to a set target is going to be beneficial. But definitely long-term secondary prevention hypertensive treatment should be part of that therapy for patients.
Now, I've just noticed that there's some really good questions coming through from into our chat box. So I think we'll head over to Gary and give him an opportunity, because I think this raised some really important issues.
Thanks, Matilda. Yeah, there is some good questions there. And the first one probably relates to the fact that, interestingly, in quite a few rural hospitals, it may actually be easier to get a CT than an ultrasound. Sounds like Ashburton is the case in point.
Yes.
Have you got any comments about the relative value of CTA carotid versus ultrasound, if that's all that is available? That's question one.
I'd be interested in what Teddy thinks about that. I mean, if someone comes in with acute stroke and they're on a pathway towards possibly getting thrombolysis or clot retrieval, then we're going to do a CTA together with the CT. We can do that. We've got the CT. We're going to go straight to a CTA, in which case we're not going to be thinking much about the ultrasound. We certainly, if it's a TIA setting, we would definitely put them in for an ultrasound of the carotids rather than just go straight to a CTA.
Yeah, thanks, Steve. I agree. Look, it's again controversial more with the amount of resources available and how much reporting we're creating for our radiologist colleagues. Myself, I have been a fan of just doing a one-stop shop. If you're doing a CT, you just do the whole bang for your buck, imaging the carotids, and the added value of a CTA is that it also allows you to image the intracranial portion of your vasculature, which the ultrasound doesn't tell you. So when you don't have a extracranial carotid stenosis, it doesn't mean you don't have any narrowing or atherosclerotic disease elsewhere, and that might be important in understanding the causes of the TIA and for you to allow more targeted treatment. For example, if someone keeps having recurrent TIA despite a normal carotid ultrasound, that could be due to intracranial stenosis, and that, even though there's not really a lot of intervention to offer you, at least you know what's happening, and that can allow you to sort of stratify risk and things. The other value of a CTA would be, it doesn't happen often, but sometimes people with a large clot in the brain can present like a TIA or fluctuating symptoms over a few days. On occasions, you'll find that it's sort of urgent outpatient CTAs will pick up a major vessel occlusion in patients that otherwise would not have had it done. And some of these patients will go on to have a major stroke. One of the 20% in the high risk groups that probably already had a clot sitting there. You just don't know about it. But I think it really needs to be tailored towards resource availability. You don't really want to create extra 20 minutes per patient for your radiologist to report with a CTA. But having said that, having tried to look at carotid ultrasound images, I think there are more images than a CTA. So I think if you can't get an ultrasound in a timely manner, but you can do a CT, and if your centre's radiology reporting, that's not an issue with reporting CTAs. I think the CTA is just as good, if not better, than a carotid ultrasound.
Great, thanks for that. There's a few questions around secondary prevention as well too. You've already touched on how aggressive you need to be with blood pressure lowering. Does it make a difference if we're dealing with the TIA versus a completed stroke? And the other sort of subgroup, is it the very elderly? What sort of targets would you sort of aim for in that group?
That's a really good. I'll try and hit out of that one first of all, Teddy. So I think in general, post-stroke or post-TIA, I would have the same target of trying to get below 130 systolic, but then that might be qualified by the person in front of you, as you're implying, Gary, who may have major debilitation from a stroke, very unsteady in terms of mobilization. Maybe you've got issues of postural hypotension playing in, issues of quality of life. As you say, in the elderly, what are you going to target? Often in that kind of very well aged group, 90, hypertensive, may or may not have had a stroke or TIA in the past. I'll often accept a much higher systolic than I would in a younger person.
I would agree with what Steve said. It's a difficult area, particularly when you get to the very elderly, and you do have to think about resetting that target, because the tolerance for relative hypotension is just not as good as, say, a younger patient. And in terms of complete a stroke, I guess, depending on, again, the course of the stroke, if you have a narrow artery in the brain, you probably want to avoid excessive hypotension anyway. Or if you, in an acute period when there's carotid stenosis while you're waiting for surgery, you probably would rather the blood pressure being slightly higher than low. But these are a specific subgroup of patients to consider, which is not commonly encountered, I think, in your practice.
Thanks, Matilda.
Are there any more questions there, Gary?
There was just a couple, I think, which have probably actually already been answered reasonably well. I mean, one was, it sounds like there's really no difference nowadays between aspirin naive patients and those who aren't. I think that's correct. There's nodding. And the other question was around continuing with a single antiplatelet agent, very long time, like permanently, as you would in the setting of cardiovascular disease. And I assume that would be the case as well. Is that correct?
That's what I would do, and I think Steve's agreeing as well.
And I just wanted to clarify that we would just reserve anticoagulation for those patients with atrial fibrillation as their risk factor. And, for instance, I had a chat the other day who was already on dual antiplatelet therapy. He was having further TIAs, and someone proposed that perhaps he should be anticoagulated. But I felt like that was just getting into, intervention for this because you felt helpless.
It's a difficult area, but a very good question. Recently, there have been, again, depending on the etiology, okay, the cause of the stroke or the TIA. If you have someone who just had an event without arterial stenosis inside the brain, or extracranially, that's not significant enough for intervention, then there's definitely no evidence that anticoagulation would be helpful. There's been a couple of recent sort of studies looking at people with stroke of undetermined etiology. These look like embolic strokes rather than your sort of watershed or small lacuna strokes. They're being studied with rivaroxaban and dabigatran, and both of them demonstrated no evidence of benefit. After a few thousand patients being looked at. If you talk about a potential subgroup of patients that has intracranial disease, narrowing of the blood vessels in the skull base or potentially inside the brain, We don't really have a lot of new data on that, but there is reasonable evidence to say from the old studies that warfarin anticoagulation would prevent more strokes from happening compared to antiplatelet therapy alone. Shifting away from anticoagulation treatment, and there have been a study looking at a few studies looking at stenting, opening up these vessels, but that has been shown to be not better than just medical treatment with antiplatelet therapy because of the risks of the procedure themselves. It carries about a 10% stroke risk when you put a stent, a bit like the heart, that you just leave in the brain. So I'm sort of beating around a bit, but at the end of the day, in general terms, there's really no definite evidence to say you should anticoagulate someone who's failed aspirin or failed your antiplatelet treatment in the absence of a targetable vessel or disease and vessel in the brain. Okay.
And I suppose in a fine print, they might have a mural thrombus, mightn't they? If they have that, cardiac substrate. We don't do many echoes. We don't go looking hard. You might find other things on the ECG to suggest that with lots of QAs and a big infarct in a recent time. I'm not sure how many echoes get done in an urban centre. We certainly would do very few for stroke in our rural centre, and it's hard to get them.
Yeah, I guess that's more getting into territory of working out that young patient too.
Yeah, and we don't do that many either. A cardiologist wouldn't allow us to, for starters, and again, the pickup rate is very low. So, personally, I don't echo everybody unless they are young, looking for the PFO, or they have pre-existing cardiac history, as Steve was alluding to, just to look for that potential clot sitting in the heart. Or if the stroke on the scan looks like it's symbolic, different territories and different ages, that you would look harder in the heart. Yeah.
We could just a bit of change of tack now, maybe into something Steve feels slightly more comfortable with. And Teddy's confessed that stroke rehabilitation is not really his forte, or really feels super comfortable. So maybe Steve, if you just want to start commenting on this, I know that there's growing evidence around rehabilitation in I don't know if I've got the right terminology, but in a stroke unit. But obviously there's benefits from having patients in their local rural hospital. And I was wondering if you could just comment on that aspect of rehabilitation and perhaps some of the sort of key features of successful rehabilitation.
Thanks, Matilda. Yeah, I think this is a really important issue for us in rural settings, especially when you think about, there's a sort of trend, and we'll talk about that when we come to these acute stroke treatments of stroke bypass, and what can be offered in a rural setting. People want to be near their whānau, they want to be close to home, and indeed early supported discharge to home and home visits, home evaluation is really important in the good rehabilitation with a good outcome in stroke. So, but on the other hand, we have to deal with this reality that there's a lot of studies out there that say that stroke units have a significant benefit to patients. There's a number needed to treat floating out there of about 20. 20 people go into a stroke unit, and one person will their life will be saved, and they'll be independent. Similar sort of numbers for that. More like say 16 for being independent. So, okay, what's in the black box of a stroke unit, if you like, that we could then reproduce in our rural hospitals as best we can? And I'll just share a slide that addresses that. Sorry, I'm just going to try and. There we go. So this is from a paper in 2011, and there are some changes in that, but not too many. If you really want to look into this in more detail, New Zealand's had some stroke guidelines going back to, I think it's about 2010, 11, but there's recent ones from Australia at 2017, and I think we've kind of adopted them as a standard. And so you can look through there. It's a living document, so it's continually updated, and it will give you, in terms of strong recommendations, weaker recommendations for something, against something. But here's a sort of the black box of stroke unit care, and you see these important components at the top. staff with a specialist interest. Is there someone on your team in your rural hospital in your area who's particular interest in stroke, who's going to make that an interest? And the same with your nursing staff, same with your physio. If you've got access to these people, the smaller you go in rural, the harder it is to find therapy staff. But early mobilisation is really important. And when I say early, they say within 48 hours. Someone's even pushed the envelope. Can we go to, within 24 hours, just, force them out of bed, get them up and get them going. And there's evidence that, no, actually they do worse if you just, push them with a poker, get them going up really early. But within 48 hours, start mobilisation, early mobilisation, prompt investigation to try and address any reversible factors, manage any complicating factors, prompt pharmacotherapy, and we've talked about that. We've talked about dual antiplatelet therapy. We've talked about hypertensive management, maybe not aggressive early on, but that's going to be important. We've talked about anticoagulation. Again, you're not going to rush in with that. And I'd usually wait routinely if someone's in AF and had a stroke. I'd routinely wait 1 week and not more than 2 weeks, and somewhere in the middle of that. Physiological monitoring, obviously that's just generally important. Blood pressure, temperature, management. Interestingly, some of these, where they compare a general medicine unit from a stroke unit, and what was the difference between these two. One of them was that the stroke unit, they manage pyrexia, they manage causes of pyrexia infection more seriously perhaps than general medical units used to. Early discharge planning, so active, proactive planning of discharge and supported discharge when people go home. Obviously a multidisciplinary team, and as much as you can try and create that in your rural area. We have in our area, we've got problems with speech language therapy. I imagine there are some areas where you don't have any speech language therapy, but all of those therapy disciplines really important. Physio, OT, speech language, dietitians. Nutrition is really important as well. And sometimes that requires nasogastric feeding. We probably don't do that as much as we should. Again, people need to define their ceilings of care, but if people's nutrition is suffering, then their outcome's not going to be as good. Some people have even trialed, do you put peg feed in routinely in people who've got a problem of swallow, put in a peg, and they seem to do worse. So that's not the answer, but to keeping them well nourished. There's a study called the Food Trial that didn't give a definitive answer to the question of when and if you should go with a nasogastric tube, but generally they showed that it's important to maintain nutrition in these people who've got a poor swallow, and there's a significant number of people that have, and so assessing for dysphagia is really important. We can train our nurses to do basic and evidence-based assessment for dysphagia, simple bedside swallow test. Will that miss some silent aspiration? Yes, it will. Some advocate for a citric acid test. I'm not sure whether Teddy wants to comment about that, but there's several speech language therapists that are arguing for that. Some people would then maybe need to go on and do a video fluoroscopy looking for silent aspiration. We probably don't do enough of these, and of course we don't have access to them immediately in our rural places, but to be thinking about them. These are potentially important components that a stroke unit would address, and just to be thinking, okay, well, what's happening with the bladder? Could this person be going into retention? Is that an issue? What about the dysphagia? Should we be investigating more?
So I guess it's about I think that leadership thing probably is really crucial. Having someone who has it as a particular interest is key, and from a medical and a nursing point of view, and being deliberate and having good plans, and I guess just not letting these patients sort of slide and wallow, and making progress. One thing I'd just like to comment on during this time, we also have a real issue with access to speech language therapy, but during this COVID time, we've been utilising more, just using Zoom to get the speech language therapist to do assessment from Rotorua, which has been really fantastic. And probably we can utilise that kind of thing as well in the bits of the MDT that we're missing.
Yeah, I think that's right. I think that's a really important point to try and make the most of what we can get access to. This goal-setting approach is clearly quite important, and if you can think as broadly as possible about the needs, the cognitive needs, the memory needs, the speech needs, the swallow needs, whatever they are for this particular person in front, and to be able to set goals and work towards them intentionally, that's a really important part of rehabilitation. in a stroke unit kind of service that I think we can reproduce to a large degree, as you say, if you've got champions for stroke.
Yep. I'm going to throw Gary in there because I think from working at Dunstan Hospital, stroke rehabilitation was done so well there, and they did seem to have a really comprehensive plan. Gary, do you just want to comment on perhaps some of where that came from and maybe some practical suggestions on how that's been put in place?
I think it was being local champions, just exactly what you're saying. Many years ago, we had an occupational therapist who was, very much a champion when it comes to sort of stroke management and really early rehab, probably ahead of her time, really. And I think she's had a really lasting effect on the service. But we also have a member of our medical team again, and I think this is very important too, who's got a particular interest in stroke.
Yep. Teddy, from your point of view, anything further to add that around rehabilitation?
No, I don't really. I mean, I agree with everything that's been said, and I think part of having a well sort of combined team is to not just to progress the rehab process, but also to minimise complications. The swallowing aspiration is a major sort of mobility to result from people who had a stroke. As medical doctors, we tend to worry more along the lines of DVT prophylaxis and neurological status, but I think the swallowing part is an important aspect, not just for medical preventing complications, but a lot of patients tend to just get hooked by mouth for days on end, and that's not really comforting for particularly the older patients to sit on the ward and not having anything to eat for the weekend or a few days. But that's kind of, well, depending on the resource availability, and even I think in urban centres, that's a void situation sometimes. But I think the gist of the summary of the rehab side has been well summed up already by Steve.
I just spotted a question there that reminded me of some practice I'd seen, which was the use of SSRIs in stroke rehabilitation connected with something here around neuroplasticity. I wonder if either of you would like to comment.
Teddy might be able to give something more up to date than I. There was a study called the FLAME study, which was advocating the use of, well, in that case, particularly fluoxetine, pretty broadly for stroke. The up-to-date guidelines, as I read them from Australia, don't recommend it as a routine, but very low threshold for people who are depressed to use it. That would have certainly been my practice.
Yeah, I agree with you, Steve. There, I would consider it or antidepressant treatment for people who have developed mood disorder after stroke. Very often we see that in young people, but whether it has a role to actually play in regeneration and neuroplasticity, that's still up for debate, I think.
So now if we could come back to Teddy's kind of territory and the management of acute stroke. Things have changed quite a bit since I was first at medical school, both around thrombolysis and clot retrieval. So I'm very aware that these treatments are not necessarily available for all rural patients, and not all places have got access to CT, but I think it's really important for us to remain abreast with the evidence around these treatments, so we can kind of advocate for our pathway for our patients, and also be involved in setting in place pathways for assessment and retrieval, which has happened in the South Island. So I'll just leave it to you, Teddy, to talk us through perhaps thrombolysis and then clot retrieval, just I guess with a particular focus on the rural patient and those telehealth and retrieval lines.
Sure. Okay, I'll try and share my screen again. Slide showing, I hope. Can you see my slides?
Not yet.
Not yet? Okay.
Yep, your screen's
okay.
up.
So I showed you the slide before. So the main aim of ischemic stroke reperfusion treatment is to get rid of the clot that's causing the blockage as soon as possible. And you know, we all know you can, the options are thrombolysis or clot retrieval. And thrombolysis, which we'll touch upon first, it literally is looking at lysing the clot, and it is still the most rapidly accessible intervention for ischemic stroke. And this is becoming slightly controversial, this topic of which agents, whether to treat with, but in general, most places still use alteplase. In the South Island, I think now everybody in the South Island who can thrombolyse patients has switched to tenecteplase, which we'll touch upon later on. The benefit of stroke thrombolysis really does depend on the time to treatment. You know, thrombolysis doesn't work for everyone, and part of that is the delay. Okay, so thinking back to the concept of the ischemic core, you know, the dead brain that's enlarging over time, and that's the very reason why with each hour and a half delay, the benefit reduces. So this is actually the meta-analysis of all the thrombolytic trials with predominantly alteplase, published a few years ago. So the number needed to treat, this is to achieve a functional independent state in 90 days, is the lowest or the most beneficial in the first 90 hours. So every 4 patients you treat, 1 is independent, and there's some benefit in the others who were treated. Whereas this NNT sort of increases exponentially. So in a 90 to 3 hour window, it doubles. And then in the 3 to 4.5 hour window, which is the current sort of limit of standard window of thrombolysis, the number needed to treat is not so great, 1 in 14. And it is about how quickly you can treat the patient. So I'll give you a couple of examples. This is a patient that came in a couple of years ago, elderly man who's independent with a posterior circulation stroke. You can see the lesion there. The stroke scale is high, came in quite early. He got alteplase at that time, and it got treated within that magic 90-minute window mark. And he made a full recovery over the next 24 hours and a repeat scan. He was in a trial we were running. We're involved and he had a repeat perfusion scan. You can see the perfusion no longer shows occlusion, and there was no infarction on the scan, and he actually walked out within 48 hours of a major stroke. Similarly with alteplase, this is a woman, young woman who walked in with an unusual presentation because she had no speech output and no limb weakness. So there was a slight delay in getting it scanned, but you can see there's a large area of perfusion problem because she had a clot too far down in MCA, but too far for us to get to. And she got tenecteplase and got treated around the 90-minute mark. And, you know, I remember her quite vividly because she started talking within 5 minutes of thrombolysis, because TNK, you just push it as a bolus. And again, the next day she had no stroke on the scan and the perfusion was normal and she walked out speaking normally. So it is about how quickly you treat them. But I do have to say that, you know, this is based on the old data. There's not everybody will benefit overall. According to the old data, only about a third of the patients would have some sort of benefit, and about 60% would remain the same. And thrombolysis can harm people. You know, we see perhaps 1 bad hemorrhagic transformation once a year, luckily in our centre. But overall risk of brain hemorrhage is about 3% in the routine window. And there are reasons why thrombolysis don't work in some patients, because if you already got a large area of dead brain by the time you treat the patient, you're not going to win. And if anything, you will increase the risk of hemorrhagic transformation, because when blood restores into the area of dead brain, there's breakdown of the blood-brain barrier and the blood, and you can bleed easily. Or conversely, if you treat the patient without a clot, which can be difficult to tell, for example, people who had carotid stenosis and they had a hypoperfusion event, thrombolysis isn't going to fix that. Or you select patients who are old or had pre-existing premorbid conditions that would have a adverse impact on their outcome. But I think the biggest problem is the delay to treatment, and certainly that has been the issue around New Zealand, but which is improving over the years. And our average door-to needle time in the country as a whole is still about an hour. So there's still room to improvement, because if you want to treat a patient early, if it takes an hour from arriving at the hospital to getting the treatment, because you need to get CT and blood pressure and everything under control, it's going to be very hard to get people into that early time window. And the last bit is, if you have a large clot, it's less likely to dissolve with a thrombolytic treatment, which we'll touch upon later.
So I guess, Teddy, from that, your patient selection is really important to influence how successful you are and that time frame. And so what would you say if you had sort of the optimal patient, what would be the limit of the time frame in which you'd deliver treatment?
Yeah, so this is actually the slide I'm showing. So the current window is 4.5 hours. I definitely would treat patients within 4.5 hours of onset or last known well time, provided their scans are normal, provided they don't already have established stroke or a large core. In terms of beyond that, to me it's slightly controversial, but I would on occasions treat them. If they don't have a target, we can intervene. So there's some suggestion from 2 major papers published last year that if you use advanced scanning, with the perfusion maps, that you can thrombolyze patients up to 9 hours from last known well, or wake up a stroke. But it does require MRI or alternative to CT perfusion, which is not available in all places in New Zealand. The benefit though is similar to 3 to 4.5 hour windows, and the number needs to treat for these patients is about 14. But there are various reasons why the trials weren't that successful, because most of these patients had a large clot that thrombolysis wasn't going to be useful, but you would go for clot retrieval now, which I will go on shortly. So just a topic about wake-up strokes, or beyond the routine time window. So do you actually need those fancy scans that I've been talking about, and Matilda has mentioned that a lot of people wouldn't have access to, which is a reality of the health system setup. But for a particular example, this is a patient from Ashburton, actually, but not Steve's patient, recently, who had a wake-up stroke. So presented to the hospital 2.5 hours from wake up, went to bed about 8 hours ago. So essentially we had no idea when the stroke happened, and there was no infarct on the scan, but you can see there's a disruption to the blood flow in the right carotid artery there. So he came to our centre, and we were offering clot retrieval, but we repeated the scan, and the scan's still fine, and we're still part of international trials that's looking at extending the indications for treatment. We didn't actually do perfusion on him. We just needed a non-contrast CT to make sure there's no contraindications, and for us to be able to think about thrombolysis. And he actually had no impact, despite 4.5 hours from waking up, and probably about 12 hours from going to bed normal. And he had got randomized into a treatment arm, but the thrombolysis agent wasn't going to touch the ICA clot at that time. But he had a clot retrieval and had a small infarct and went home. So at this point I'm trying to make here is that you don't really definitely need advanced scanning to be able to make treatment decisions, but that's going to be ongoing subject of investigation. Just to sum up, it's this bit about thrombolysis. I'm going to move on to clot retrieval now. Not everybody will benefit, some will be harmed, but I think we just need to be sensible about selecting patients. You shouldn't treat all strokes that come in early, but if you can treat them, you should make sure that that you can make sure they have all the favorable imaging features that would minimize the potential for harm. And before moving on to clot retrieval, there's this subject about tenecteplase and alteplase. I think a lot of you would be more familiar with tenecteplase and alteplase because the treatment for STEMIs in a rural setting. And in stroke, there's been a few studies, and it appears to be actually far superior at dissolving large clots early compared to alteplase. and it's safe in people with mild strokes. And I won't go into the timeline of the changeover, but all the self-Allen centers now are using connected places routine treatment for stroke thrombolysis. And just to give an example, this is a patient that had a MCA clot, had a large syndrome, but had a connector place done and went to the angiogram, and the clot's gone, and he actually walked out of hospital because the clot was dissolved quickly with a small stroke within 2 days. Matilda, any questions before I move on to clot retrieval, the last segment?
I guess just putting it into our context, I guess that these patients where we don't have access to imaging, they need prompt transfer so that those decisions around intervention can be made. I guess that's where it sits, and some of us do have access to the imaging and to utilise it. Anything else, Steve, that you'd add from your perspective?
No, I don't think so. Often the ambulance services have bypass procedures in place now, don't they, when they've got a fast positive situation, and they'll just get someone going quickly to where they can be imaged. I'd have to say that, as a physician working in a rural setting, when we first started thrombolysing people with stroke in the early days, there wasn't quite as much accumulated evidence, wasn't quite as much real world evidence, and there was a nervousness about doing it. But again, I think that time has proved, if you select your patients well, if you adhere to the the contraindications, some of them have become more relative contraindications now, haven't they, Teddy? Yep. And it's a good service that we're providing to people, and at the end of the day, it's not so much about saving lives, but about helping people to independence.
Yeah, I guess, moving on to clot retrieval, Teddy, I guess just bearing in mind that this might be quite a new concept for some people who won't have had any patients who've undergone this.
Yep. Okay. Hopefully, it will be of interest. So clot retrieval is really set up because the chances of the thrombolytic agent dissolving large clots quickly are low. So for example, if you got the main branch of the artery in the brain, the MCA, you got about 30% chance of dissolving a clot within 2 hours of the drug being administered. So not high, but not zero. But if you got a internal carotid artery or the main artery, the basal artery, you basically have no chance of actually killing the clot with lytics. And clot retrieval is just what it is. The clot retrieval is an Australasian term. Thrombectomy is the other term, but it's similar to what the cardiologists do, but to the brain. You basically insert a wire, the radiologists do it, and they pass the clot, and then they usually deploy a stent device like this, and then the stent sort of absorbs the clot, and then you pull the clot out and literally get rid of reopen up the artery again. And this is historical, really. I always show this because it's marks the first ever clot retrieval case, and when I was still a young doctor back then. It's quite amazing what you could do. At that time, it was quite amazing because we mentioned earlier, when you had a stroke previously, it's more like tucking to bed, good luck, wish you the best, and hopefully rehab will fix you right. But this is a first time that in my travels that at that time, we witnessed a patient with a major stroke that was fixed. So this is a patient that came in with a clot in the MCA, similar to the ones I showed you before. But she had a clot removed, 2 centimeter clot there, and despite coming in with quite a profound hematopoiesis and neglect, she was able to walk out of the hospital within a few days without the need for rehab. And then this is a busy slide, I'm sorry, but this is just to show you, compared to thrombolysis, you got 2 to 3 times the efficacy of opening up the clot with clot retrieval. And compared to thrombolysis, your chances of a normal outcome, remembering though this is big strokes, subset of patient with big clots, not just any stroke. So their outcome overall, according to these landmark studies, is about 1 in 2 treatment. 1 in 2 patients with clot retrieval would be normal, compared to about 1 in 4 with thrombolysis. So it nearly doubles your rates of a successful independent outcome compared to medical treatment, which is thrombolysis. And speaking of the time windows, again, it's an expanding area. The trials initially look at sub 6 hours. That's a random number, and the NNT is good, but you know, that it's 6 hours. It's difficult for a lot of you that work in areas that you know, that don't have really access to a transport to be able to ship the patient away to a centre that's capable of doing this. But the problem, the issue with the 6 hour thing is that, so this is a slide showing you how quickly the brain dies per minute. You know, I think we all heard of this 2 million neurons a minute concept, but there's a wide range. So some people's brain dies slower, 35,000 or less neurons a minute, but some patients, unfortunately, you just can't help them because their brain just dies quickly, because the mechanism of the blood flow, you know, the videos I showed you earlier, fails quicker in some of these patients, but some of these patients can maintain that mechanism for a long period of time. And now we know, you know, utilizing this sort of variation concept where you can look at individuals' blood flow using these advanced scans, it's shown that you can offer these treatment up to 24 hours, provided you can somehow manage to show that the brain's still viable at the time prior to intervention. And the number needed to treat is actually slightly lower. This is a so-called late window paradox, because you know, the later, I guess, you are, the more severe your deficits are at the time of presentation compared to the patients who had been treated. But in general, you know, with clot retrieval, any time window, it's quite a good therapy to return function. So just in terms of coverage for clot retrieval, or in terms of how its technical aspects, how is it done, and the risks. So in New Zealand currently is by radiologists. There's the young neurologists coming up that wants to be interventional neurologists. So we're following the footsteps of cardiology. In the country as a whole, we are pretty successful, between 80 and 90% success rate. It's generally quite safe. You know, you have about 1% extra risk of bleeding to the brain with treatment. But I guess compared to a potential devastating outcome without getting rid of the clot, that's quite a low risk to take. And life-threatening complications like perforation, so that should be less than 1%. And I just want to show you this summary slide from Christchurch. This up to the end of February, we've done over nearly 220 procedures, and mostly big clots, carotids, and the proximal large MCAs. But this is the take-home figure. You know, over 1/3 of the patient, just over 1/3, went home, despite coming in with a major disabling stroke to start with, without the need for inpatient rehab. So this is quite a major turnaround in terms of how successful it can be to a patient. Again, just to give you another example, 46-year-old woman came in with a carotid occlusion, you know, again, large area deficit. You probably don't need this to know that, because the carotid is blocked there. And she had a artery opened up quite quickly, and, you know, she had no stroke on the MRI and went home the next day. And in fact, you know, this is her using her paralyzed hand that was paralyzed 2 hours before this photo was taken after the procedure. So, you know, if anything, we are creating TIAs, but, you know, it is that so good, this procedure, that if successful, it can be quite miraculous. In terms of the current status of coverage in New Zealand, you know, depends where you live, but there are 3 centres that can do this: Auckland, Christchurch, and Wellington. Both Auckland and Christchurch are now 24/7. Wellington is slowly increasing its capacity, and hopefully will be 24/7. But the planning has meant that all patients can potentially reach a clot retrieval centre within 6 hours of notification. And specifically, it's the South Island. We do offer coverage to the rural centres for acute stroke patients, helping physicians, local physicians, to decide on whether to thrombolyse a patient. Even if they're not clot retrieval candidates, or if they are potential clot retrieval candidates, we use telemedicine to look at a patient and look at the scans to help them make that decision. And there's quite a good network that's up and going. I don't have Nelson there because they are using telemedicine with Wellington. But we have coverage in all the DHBs. We can link up to Dunstan. We have coverage in Oamaru, Dunedin, and Invercargill, as well as now Queenstown, which is the latest hospital to join us. And you literally have a machine. Each hospital has different machine. We can see the patient through that and examine the patient through the local doctors, have access to the scans in real time, and we'll be able to facilitate transfers or facilitate a local treatment decision if they're not a clot retrieval candidate. Just a couple of examples before I finish this segment. We had quite a few successes already. So this is a grey mouth patient with wake-up stroke, 13 hours, had a big long carotid clot removed, had a small stroke, and she went home without rehab. And the most recent success story, I guess, is Queenstown. Queenstown had their CT up and running, first CT last year, and quite keen doctors there, Susan and David Dixon, and they got the team going. This is a simulation they were running with an actor using a fixed TV and a camera, and they were able to have their pathway and protocol set up with the necessary baseline scans of the CT and the angiogram. And we were able to actually, in fact, treat a patient there in December soon after it opened up. The patient, elderly patient who was independent, came in with a distal clot in the brain, too far for clot retrieval, but well within thrombolysis window. So she got thrombolized and had no stroke on the CT on follow up, and she walked out of the hospital. And in fact, she was didn't know she was quite a famous person at that time, and it's good. I think this is increasing capacity and coverage for treatment for patients in the South Island, and that's probably all I have to say for clot retrieval, Matilda. I actually did prepare a couple of slides on COVID. I think that was something that's generating interest. Shall we move on to that, or?
Teddy, I'm just a wee bit aware of time. This is what always happens with these. And I am quite happy to do those things. I'm just wary that people may need to go, and feel free to leave if you need to and if you wish. But I think we should. I've got my children are asleep.
It's literally 2 slides on COVID.
But I think we should just carry on. I just want to comment. Your enthusiasm is awesome, and I was working at Queenstown at the time that those plans were put in place. So it's really cool to see that success, and it's quite amazing. Sort of seems like such a simple therapy when you see those tiny little clots there that cause so much havoc. It's pretty satisfying to see those outcomes.
Thank you. Yes, I think it's the great outcomes that we're seeing that's driving this for all of us. And I think it's just good for people to know that hopefully it's the same everywhere else in New Zealand, but in the South Island at least, there's a setup to be able to look after these patients. We've had clot retrieval from all the South Island rural hospitals, including Invercargill, Oamaru, and not quite Dunstan. No, not yet Dunstan, but we'll get our first one shortly, I'm sure.
Come on, Gary. Gary, I'll just touch base. Is there any questions that have cropped up in the chat box?
Ram had a question about cholesterol embolism and whether or not that's a real thing.
It is real, but it's probably not as common as people think. The cholesterol embolism, it's usually due to a rupture from the carotid artery plug. So if it's from a carotid artery emboli, then that's where you see it. But most of the big strokes, certainly that we see, would usually be a thrombus from either the heart or an unknown source.
Cool, Teddy. You move on to your Susan's here. Congratulations, Susan, on your excellent work with Teddy. Susan was as enthusiastic as Teddy and had these amazing advertising posters for all the staff, getting them behind the setup. So.
I was gobsmacked by what Susan came up. I should have shown this.
But Teddy, go ahead with the COVID stuff. I hadn't,
Okay,
thought about,
so
I hadn't thought about COVID for 60 minutes, but, you know,
yeah,
let's get back into it.
not much to say really, because we're lucky in New Zealand. But I think how it's affected us is that we have seen globally, in New Zealand and elsewhere, reduced stroke presentations. And that's probably out of fear of the potential risk to get infected at the hospital, unfortunately. But what we've done, I know every major hospital and I think also smaller hospitals as well have their own individualized hospital protocol to approach to patients who might be suspected or confirmed case of COVID, like using PPEs, and it takes a bit longer to do scans because of the precautions. But luckily, in our local experience, we haven't actually had needed to treat a patient with it. But we envisage it would have added probably extra 30 minutes of time because of the extra preparations required to ensure safety of staff and patients. And in terms of its relation to stroke, it is slightly controversial, but I think it probably can cause stroke in patients with a severe inflammatory response. This is a case of series of 5 published by a group in New York of people under 50 who had clot retrieval. They've seen a rise in it, and it's probably is a real observation. But I think the overall risk is still likely to be very low, because we know infection itself is a risk factor for acute stroke due to the thrombotic effects driven by the inflammation. I guess with COVID-19, some patients have quite a severe inflammatory reaction, and it's not unsurprising that some of these patients will end up experiencing a stroke. But luckily, we now have no cases in New Zealand, new ones, and hopefully that will continue. And hopefully this is not something we'll see. Yeah. And that's really all I have. Sorry for being wordy.
No, don't apologise. And I'll just check in finally just with Gary. Is there anything else that's come through, Gary? Last moment questions. And I will say I can always forward questions on to via email if there's specific things people want to ask.
Just that difficult area of posterior circulation strokes, about making the diagnosis and treatment. Have you got any tips there?
Tips. Yeah, it's a difficult one. I think a lot of the times they can get missed because of the non-specific nature of the symptoms like unsteadiness, dizziness. But I think what you need to watch out for is if, apart from feeling dizzy and unwell, if they have, say, one-sided limb ataxia, so incoordination, or if their speech is slurred, or they experience visual symptoms like double vision and their eyes are not actually moving properly, then you really need to investigate them forward. One of the one thing that I've noticed that has been missed a few times is that young people with just isolated dizziness that don't get stroke picked up, but that's a difficult area. You know, it's a CT may be normal if you scan them acutely, and the other flip side of the coin is the more severe ones. In Christchurch, there had been no clot retrieval for the basilar artery, the big branch in the back, for the first 2 years that I came back to work here. That's because these patients got missed, because they came in looking like they're unconscious or had a cardiac arrest, and was in fact actually just because they had a clot sitting in the brainstem that's stopping their autonomic function from performing. And these patients get missed. And in the last year, we've seen increasing pickup of these. So I guess in the severe cases, just be severe presentations of unexplained cardiovascular collapse or unconsciousness, and particularly in people in the right age group with risk factors, just be worried that they might have had a posterior circulation stroke. And if you're going to scan them anyway, I think I have a low threshold to do a CTA.
Yep. Well, that will, I think we'll bring our webinar to a close now. Thank you so much for everyone's time and attention, all those who've been listening out there and watching and sending your questions in. There are a few questions that have just come through in the end that I will pass on to Teddy and to Steve. Please just remember to complete that survey. That's the link to that's in the chat box. Really, really big thank you to Steve and to Teddy for your contribution this evening, and for the work that's gone into creating those pathways in the South Island, Teddy. Thanks also to Gary and to Rory, who's in the background doing all the technical stuff. And remember that tonight's webinar will be posted on Leaning on Fence Posts, Rory's blog, and can be watched and listened to at a later date as well. And I'll send you the link out for that. And I don't think there's anything further from anybody. We'll bring it to a close. Thank you so much, everybody.
Thanks, Matilda. Good night.
Thank you, Diano.